Good afternoon and welcome to ALS United's annual Education and Resource Summit. This is session 9, Pulmonary Care in Amyotrophic Lateral Sclerosis. My name is Eileen Margenat, and I am a Care Services Coordinator for the Lower Hudson Valley. Before I introduce our speaker, I would like to invite you to utilize the Q&A box for any questions or comments you would like to share. It is my great honor to introduce Dr. Alex Bain. Dr. Bain is an instructor of pulmonary and critical care medicine at the NYU Grossman School of Medicine, where he cares for patients in the NYU Chronic Respiratory Failure and Home Mechanical Ventilation Program. He is a graduate of the University of Pennsylvania Perelman School of Medicine and completed his residency and fellowship training in New York City. Thank you, Dr. Bain, for spending your time with us today.
Thanks so much for the introduction, and good afternoon, everybody. It's an honor to be here, and I'm happy to speak to you today about pulmonary care in ALS. I'm going to go ahead and share my screen. I have some slides prepared for you today. Okay, is everyone able to see my screen? I'm going to assume that's a yes. Okay, so I am a physician, a pulmonologist. I work in the chronic respiratory failure clinic at NYU. I work with Dr. Philip Choi, who's the director of our chronic respiratory failure program, as well as the co-director of our multidisciplinary ALS clinic at NYU, which was just formally started up several months ago with Dr. Jinsey Andrews, who joined us at NYU. So I'm happy to talk to you guys more about that at the end of the talk. I have no disclosures. So today, my goal is to make sure that we can all recognize the respiratory manifestations of ALS, understand the management of respiratory failure in ALS, and understand the importance of the multidisciplinary care team that hopefully involves a pulmonologist that is well integrated into the team, because I think the pulmonary and respiratory care is really crucial in managing this disease. Um, so, how does ALS affect breathing? So, as I'm sure you all know, ALS leads to weakness of your muscles through its effects on the upper and lower motor neurons. So, when you breathe in, you have some muscles that are involved in that. The primary muscle of breathing and of inspiration, which is breathing in, is your diaphragm, which is the muscle that separates your chest cavity from your abdomen. You also use what are called your external intercostal muscles to help breathe in. Those are the muscles in between your ribs, as well as some of the muscles in your neck, which are sometimes more specifically referred to as your scalenes or your sternocleidomastoid muscles. And weakness in any of these muscles leads to shallow breaths and inability to take a deep breath in, which we call hypoventilation, so low ventilation. Similarly, ALS affects the muscles of expiration, so breathing out. And those again are the muscles in between your ribs, as well as your abdominal muscles, which can also help to exhale. The reason that is very important to us in thinking about respiratory care for ALS is because that weakness in exhalation leads to impaired coughing strength, which is very important to preventing infections and clearing secretions. The other important muscles from a respiratory standpoint that are affected by ALS are the speech and swallowing muscles, sometimes referred to as the bulbar muscles. And weakness or spasticity in those muscles leads to difficulty managing oral secretions, increases the risk for aspirating those secretions, having them go down the trachea, the windpipe, down into the lungs, instead of being swallowed down your esophagus into your stomach, and can increase your risk for respiratory infections and pneumonias. This is a very complicated graph that I don't want us to get too bogged down in, but I just wanted to point out that inspiratory muscle weakness here again can lead to stiffness of the chest wall and inability to expand the chest to breathe in. It can lead to problems with your breathing during sleep and can increase your sensation of shortness of breath in your work of breathing, all of that leading to that process I referred to earlier of hypoventilation or taking small breaths in. Similarly, expiratory muscle weakness leads to that impaired cough, which ultimately will lead to an increased risk of pneumonia. And then finally, those bulbar muscles being weak in the upper airway leads to swallowing impairment and again, increased risk of aspiration and pneumonia. So this is just a quick flow diagram showing again that respiratory muscle weakness in ALS does increase that risk of pneumonia, which is a major cause of illness, infection, and death in ALS. So it's really something that we spend a lot of our time as the pulmonologists trying to decrease the risk of pneumonia. So those low lung volumes and ineffective cough lead to secretions that either get aspirated into the lungs and then build up and can lead to a respiratory tract infection. So what are the signs or symptoms that might indicate that a patient with ALS is developing respiratory muscle weakness? And I think it's important to emphasize that there's a lot of patient-to-patient variability in when respiratory muscle weakness occurs and how severe that respiratory muscle weakness is. And finally, how quickly the weakness progresses. We know it will progress, but we don't know how quickly. And it's very hard sometimes when we're counseling patients to give them an idea ahead of time of the rate of the progression of the respiratory muscle weakness at the very early course of their disease, because patients truly progress at different rates. So the symptoms that we often look for and we'll ask patients about when they first come to us in clinic, and then we will continue to ask them as we see them in follow-up care, is if they have shortness of breath when they lay down flat, and that's known as orthopnea. Similarly, we'll ask if they have shortness of breath when they exert themselves. Now, depending on a patient's mobility status at the time, that may be a more difficult symptom to assess if they're very limited and unable to walk. And another way that we sometimes get at very early symptoms of shortness of breath and respiratory muscle weakness is if patients are ever in a pool or in water, they may describe feeling like it's very hard to breathe and they're very restricted. And that is really just the weight of the water pressing down on the chest wall and making it more difficult to get in a full breath. Difficulty with sleeping is another area where we often see the earliest signs of respiratory involvement from ALS. When patients sleep, particularly during REM sleep, which is the kind of dream stage of sleep, most of your muscles are basically held paralyzed by your body in a normal state. And that's to prevent you from acting out your dreams. So because many of those muscles are not able to assist in breathing during dreaming, then if you are prone to having shallow breaths because of muscle weakness, that will be exacerbated during sleep in a way that it is not apparent during the daytime. So we will often ask about issues with sleep or feeling short of breath when laying down. Morning headaches and excessive sleepiness during the daytime are often things that manifest outside of sleep that may be related to those issues with sleep disordered breathing. And finally, a lot of times we'll see patients in our clinic who may not yet feel short of breath, but we can see from a close examination that some of those, what we call accessory muscles, the muscles in the neck that can assist with breathing, are very involved in their breathing just when they're sitting quietly at rest. And that to us is usually a sign that they have some degree of respiratory muscle weakness. So how do we assess respiratory function in our ALS patients? The primary test that we perform is a test called spirometry. And spirometry, as you can see in this picture, involves a patient putting their mouth around this tube here, taking a deep breath in and then blowing as hard as they can out into the machine, where we get a measure of how much air and how quickly they can push that air out. Um, as you might imagine, in patients with ALS who have muscle weakness that involves their facial muscles, it can be a very challenging test to perform, particularly over time as muscle weakness advances. However, it is a really important test for us, and we use that in clinic on a regular basis to assess a patient's respiratory muscle strength and to measure disease progression. Um, we also perform a similar test looking specifically at the muscle forces. And that's called the maximal inspiratory pressure and maximal expiratory pressure. And again, that is a test that is very difficult to measure in patients with any sort of bulbar disease or difficulty forming a good seal on the machine. Um, there is another test that is called a sniff nasal pressure that can be a little bit easier for patients with bulbar disease to perform. I will say it is not widely used in the United States. I think it's more common in Europe, so most patients probably will not do a sniff nasal pressure test, but it is another option that is available in some centers for measuring respiratory function. And finally, there's another test called a peak cough flow. And the peak cough flow is important because, as I was discussing earlier, we are interested both in the strength of the muscles of inspiration, but also those muscles of expiration. And again, the muscles of expiration are what you need to really generate a good, strong cough. And we know that the risk of pneumonia is increased if your cough is weak. So that is something that we can monitor in our clinic. Probably the best way to monitor that is just by asking patients, if they feel like they have difficulty clearing their secretions or coughing themselves. We'll listen to their cough and we can get a pretty good idea just from that. But we can also measure it, and they have shown, over time that if you have a peak cough flow under this value of 270 liters per minute, the number's not that important, but all that to say, if it is impaired to a certain extent, we begin to think about giving patients a cough assist device to help them with secretion clearance and assist their cough. Okay. One question that comes up frequently is there anything that can be done to strengthen my respiratory muscles? So this has been studied in several small trials. They've done both testing trials of the inspiratory muscle training and expiratory muscle strength training. And there was a study from several years ago that looked at expiratory muscle strength training using a device like you see here. And that was used in early disease, so patients with overall relatively preserved lung function still. And they did a fairly rigorous protocol of 5 days a week expiratory muscle strength training for a total of 8 weeks. And what they saw was that the patients who did the strength training compared to those who didn't did have an improvement in their expiratory muscle force, and their swallowing function was relatively maintained compared to the patients who did not do the strength training and had a worsening of their swallowing function. That being said, in real world conditions, I think that the benefits of expiratory muscle strength training are not fully definitively known. We do think that it's probably most helpful in early stage disease, and the benefits later on are probably less, and the long-term benefits of this have not been evaluated. So what are some of the treatment options that we discuss with patients when we are um, seeing patients as the pulmonologists in ALS clinic or chronic respiratory failure clinic? So I'm going to talk to you about a number of devices that we use, and that's, kind of the bread and butter of what we do in our clinic, which is prescribe these devices. So the main devices are are called non-invasive ventilators. And those really come in two flavors. There's BiPAP devices and home ventilators. And I'll talk to you about some of the differences there. But overall, I think the takeaway is that they're performing an overall similar role. And we lump those together under this general term of non-invasive ventilation. There are also devices that we use that are most commonly called a cough assist device. Again, for patients who have an impairment in their ability to clear secretions or cough. And that device is more technically termed a mechanical insufflation exsufflation device, but we can just call it a cough assist for our purposes. Um, we also often prescribe portable suction machines, which we'll go over a little bit, and you can think of that as like the suction machine at a dentist for clearing out those secretions that pool in the mouth. And then we can also talk a little bit about some of the medications for treating pooled secretions. Okay, so why non-invasive ventilation, which is the BiPAP or uh, the home ventilator machines. So there have been a number of studies at this point that have shown that non-invasive ventilation improves both quality of life and length of life in patients with ALS. They've also shown in these studies that there's a slower progression of decline in respiratory function in patients um, who use non-invasive ventilators versus those who do not. That being said, there's only been one randomized clinical trial that has looked at this question, and that was published back in 2006. It's highlighted here in this box in red. And that was a very small trial that involved only 41 patients who were randomized either to the non-invasive ventilator or standard of care at that time, which did not involve any non-invasive ventilation. The benefit in that trial, it should be noted, was most largely seen in those who did not have severe bulbar disease. Um, this is a more recent trial that was much larger. It's an observational study, but so it's not a randomized trial, but it was a matched study where they got patients who were very similar to the ones who got the non-invasive ventilator, but did not, but they weren't truly randomized. And this study, which was from the University of Pennsylvania, again showed that in patients who primarily had limb onset ALS, so those with less prominent bulbar symptoms, they were able to show a significant increase in survival for those who used the non-invasive ventilators. The important thing to note was that higher self-reported hours of daily usage was associated with better survival amongst those who used non-invasive ventilation. So the longer that the patients were able to wear it, the more benefit they derived from it. And I'll talk a little bit about why we think that might be. Um, okay, so I want to talk a little bit, as I previewed before, about the difference between a BiPAP and a ventilator. So this device that you see a picture of here, I think if any of you have seen ads on television for CPAP machines, they look very similar to this. This is a ResMed BiPAP device. Um, um, BiPAP devices are often what we prescribe in patients who do not yet need continuous ventilation assistance throughout the day, but may need it primarily for nocturnal nighttime use when they're sleeping, or maybe for short periods during the day. Um, Once they're needing it kind of on a more continuous basis during large parts of the day, then we talk about switching to a home ventilator, which I'll show you on the next slide. But the benefits of a BiPAP device are several. They're more compact, they're lighter in general, and easier to transport around, particularly, if you're traveling and want something that fits in your luggage, easily, even though the ventilators are also relatively compact and portable. The settings on a BiPAP device are able to be adjusted remotely. So in our clinic, where we're able to monitor patients remotely and monitor their device usage. We can also change those settings without the patients needing to bring the devices in. Um, they have a built-in humidifier, which is just a convenience of these devices. They do have relatively strict compliance criteria that are set by the insurance companies. So if you are prescribed a BiPAP device, um, it's important to be aware that the insurance company is going to um, ask that you show that you are using the device for 4 hours per day for at least 70% of days. Um, and what that means is if on one day you wore it for 3 hours and 59 minutes, and on the next day you wore it for 10 hours, you only get credit for that one 10-hour day. The 3 hours and 59 minutes does not give you credit for wearing it. And if patients aren't able to hit that 70% mark over a long period of time, the insurance companies sometimes do start to grumble about taking the device back, which of course we don't want. So we definitely work with the patient to make sure that they're able to use it and make sure that's never an issue. But it is something to know ahead of time. The benefit of a BiPAP device versus a ventilator is that it is rent to own. So healthcare costs are very high, and of course the cost of care in ALS can be really, really significant burden on patients and caregivers. A BiPAP device, after 13 months of monthly payments, as kind of an insurance copay, the patient actually owns that device, and there's no ongoing payments. Contrast that to the ventilator, which you see two models of home ventilators here. They're very sleek devices for the most part. They have nice touch screens and whatnot, and are a little bit bigger in general than BiPAPs, but still relatively portable. But they are able to be used on a more continuous basis than the BiPAP devices, and most importantly, they have they have internal batteries as well as external batteries potentially that allow them to be used continuously if you're away from a wall socket, if you're out and about traveling during the daytime. So that's an important feature of a ventilator. They also have some additional modes and more alarms than a BiPAP machine. Their humidifiers, instead of being integrated into the machine, are generally external. One drawback of the home ventilator is that those settings, because it is a life support device, it cannot be changed remotely by us. It has to be changed by the provider, kind of in person. So that often means that the settings can't be changed unless the patient brings the device in for a visit. And finally, these devices are indefinite rentals. So it often comes up, what device to prescribe to our patients. Really, that just depends on sort of what is going on with the patient, where in their disease progression they are, and sort of how long we expect them to be able to get benefit from a BiPAP device if they only need it for maybe some limited nighttime use, versus if they are already relatively progressed or progressing very quickly, we may start right away with a home ventilator. Okay. So most devices that we prescribe with a nasal and oral mouth face mask. I should have included a picture for you guys here, but I'm sure you can imagine it is like a small mask that gets strapped onto your head that fits over your mouth and nose. We have much more streamlined ones that sometimes are just over the nose. Some sit directly under the nose. So there's a whole kind of plethora of different mask types that can be adjusted for patient comfort, and we can usually find one that patients are happy with and can tolerate wearing. Um, but there's also this other mode of um, sort of interface with your BiPAP or home ventilator device, or sorry, home ventilator device. BiPAPs don't have this mode, um, which is called mouthpiece ventilation, also known as sip and puff ventilation. So this is really kind of an on-demand kind of support that patients are able to trigger themselves. So it's basically this straw device that the patient has to be able to move their mouth towards, and just by um, generating a slight alteration in the flow at the straw, you can do it even with pretty significant muscle weakness. It delivers a breath, and the benefit of this is that it allows patients to get some period of daytime support, including kind of all day support, without having to wear a mask if they find that really bothersome and they think this might be more comfortable. So in some settings, we will have a patient who at nighttime will wear a face mask when they sleep, and then during the daytime, they would use a mouthpiece ventilator. Um, yeah. Okay. This comes up a lot with our patients about do they need oxygen? Um, and I think there's a fair amount of misconception about this. Most patients with ALS do not need oxygen therapy. ALS, while it affects the nerves and the muscles, doesn't fundamentally affect the lungs themselves. Um, and there's not a reason for most patients why they will need oxygen therapy at all. Um, Sometimes we see patients with low oxygens and they've been prescribed oxygen, but that's really because their carbon dioxide level is high. And their carbon dioxide level is high because they are not getting adequate ventilation from like a BiPAP or a home ventilator device. Um, Frankly, this is less of a problem in ALS than some of the other diseases that we treat in our chronic respiratory failure clinic. But it is something that can happen that, I think is helpful to be aware of. There are certain scenarios when oxygen is, of course, needed. For instance, if a patient develops a pneumonia from aspiration, then they may need oxygen. If they've developed blood clots in their lungs from prolonged immobility, that could lead to needing oxygen for at least a period of time. And if the patient has any underlying pulmonary conditions like COPD that is unrelated to their ALS, they may separately have an indication for oxygen therapy. So I talked a little bit about carbon dioxide, and I want to just touch on that a little bit more deeply because that's really fundamental to what we do in our clinic in chronic respiratory failure in general and in ALS in particular. So as you may remember from high school biology class, when we breathe in, we're breathing in oxygen from the atmosphere. And that oxygen goes around our bloodstream and gets delivered to our tissues. And that oxygen is used to make energy. And the waste product of using that oxygen to make energy is carbon dioxide. So carbon dioxide is ultimately toxic to the body, and the way we get rid of it is by exhaling. So we inhale the oxygen for energy, and we exhale the waste product, carbon dioxide. Um, Now, in ALS or in any other condition that causes respiratory muscle weakness, carbon dioxide can build up in the bloodstream and accumulate because the respiratory muscles are too weak to get the air in and out of the lungs well. And as that carbon dioxide level builds up, that can cause oxygen levels to go down. But again, that is not fundamentally a problem with oxygen, it's a problem of the carbon dioxide. When we see carbon dioxide levels building up, that can lead to a lot of symptoms, particularly if it happens quickly. Those symptoms tend to be things like confusion, lethargy, being very sleepy during the daytime. The way that we help our ALS patients, and again, any patients with respiratory muscle weakness, to get rid of this is non-invasive ventilation. So the support provided by the non-invasive ventilator helps to bring in the air and then expel the CO2. We have shown in multiple studies now that a CO2 that is normal can help to improve survival in a number of disease states. So we think that the carbon dioxide itself can cause problems for patients sort of regardless of disease. And one of the reasons we think that survival in ALS has improved is because with the non-invasive ventilator, we're able to keep carbon dioxide levels normal, and that can, we think, help to decrease the risk for infections for many patients. So how do we measure carbon dioxide? So the kind of traditional way of doing that is what's called an arterial blood gas. And this is a basically getting a blood draw like you would for a regular blood draw, except it has to be drawn directly from an artery. And that's actually fairly difficult to do in most clinics and even at most labs. So that's generally not done very often. It's done in the hospital very frequently where they're more set up to do that, but outside of the hospital, it's pretty hard to get an arterial blood gas measurement. There are devices called end-tidal CO2 monitors that can also measure carbon dioxide, and those can sometimes even be attached to things like non-invasive ventilators, but we think those are often not nearly as accurate. So what we use in our clinic and what we strongly favor for monitoring carbon dioxide levels, and we actually use at every visit for all of our patients, is what's called transcutaneous CO2. And this provides a highly accurate approximation of your arterial CO2 levels. And it's similar to measuring your oxygen level through a pulse oximeter. This involves a small monitor that can be placed on the earlobe or the forehead or on other parts of the body. And after several minutes of kind of calibrating, it will give you a measurement of your CO2 level. We can then use that information to help guide us in making titrations of our non-invasive ventilators for our patients. So that may require changing the settings on the ventilator. It may require a discussion about how many hours per day we're using the ventilator. But we find that information very helpful in guiding our management of patients. So how do patients qualify for non-invasive ventilation? These rules are generally set by Medicare. And there's a number of ways in which you can do it with a neuromuscular condition like ALS. One way that this is done is using spirometry. And if one of your spirometry measures called your FVC is less than 50% of what is predicted, then you can qualify for non-invasive ventilation. At your ALS center, they may have you do the spirometry while laying down, which is called supine, and that can sometimes demonstrate a lower value that may qualify you for non-invasive ventilation. They can also do the muscle force test, the maximum inspiratory pressure test, and if that is less than negative 60 centimeters of water, then you would also potentially qualify for non-invasive ventilation. The other ways of qualifying are a little bit more difficult. They involve doing arterial blood gas. Unfortunately, they don't accept transcutaneous CO2 for insurance purposes. Or you could do what's called overnight oximetry, where they monitor you overnight at home, and you have to demonstrate that your oxygen levels drop below 88%. So typically what we're doing in our clinic, and I think most centers, they're looking at those spirometry tests, they're looking at those muscle force tests, and once you qualify, then we generally would consider starting a patient on non-invasive ventilation. So how is the non-invasive ventilator monitored? So all the devices these days use cloud-based systems where their data is remotely transmitted to them. We can then go in and see that data. We always before a clinic visit will review their prior data, look at how much they're using it, how well the volume of air is being delivered. That can help guide us on making adjustments to their settings to improve patient comfort and gas exchange. So this comes up a lot with our patients of traveling with a ventilator, and I think it's really important that we're doing everything we can as the pulmonologist to help our patients with ALS, really embrace life and do as much as they want out in the world, including things like going on trips, visiting family, getting to important events, things like that. So air travel frequently comes up as a question for us in clinic, and I will say that commercial airlines are pressurized to an altitude of about 8,000 feet. Um, so that can predispose some patients with underlying lung disease to having their oxygen level drop. And that, again, is more of a concern if a patient's CO2 levels are high. For most ALS patients, it is not difficult to maintain them at a normal CO2. But it does mean that we need to kind of know ahead of time to make sure that we're monitoring you and we're in a good place before you fly. Patients are able to take their BiPAP machines or home ventilators on the planes with them. We often provide letters for TSA for security, but it's really not been an issue for us of getting our patients with all their devices to the airport and to their destination and back safely. Okay. What about a tracheostomy? This comes up frequently, as you might imagine. So, a tracheostomy is a small plastic tube that's inserted through the skin in the neck into the trachea, the airway. And then that device, the plastic tube, can be attached to the ventilator. So, that's then what we call invasive mechanical ventilation if a patient is getting ventilated through the tracheostomy. And tracheostomies do allow patients with ALS to live longer. The primary life-limiting factor of ALS is generally the respiratory function. So if a tracheostomy is placed, then that often leads to an extension of life for patients. That being said, tracheostomies, come with a lot of concerns that require, I think, generally a lot of discussion between patient, caregiver, and doctors, with neurologists, pulmonologists, and the rest of the care team, because it does involve a very significant caregiver burden and need for support. Unfortunately, in the United States, most um, people do not have access to 24/7 care through any sort of insurance, and many private duty nurses may not be comfortable providing tracheostomy care, and it really is kind of around the clock support that is needed. And of course, while the tracheostomy can help with the respiratory issues from ALS, it does not slow the other parts of disease progression. So what about a cough assist? So this is the mechanical insufflation exsufflation device. And we know that as ALS affects the respiratory muscles, it impairs our cough. So a cough assist device has basically two phases. It forcefully pushes air into the lungs and then generates a negative pressure that sucks out the air and mucus. And the reason we think cough assists are so important for our patients is because they can prevent the development of pneumonias, which can be truly life-threatening in patients with ALS. So what we do in pulmonary clinic is we assess a patient's cough and decide when we think they probably need this device, and then we'll titrate this cough assist device. Here is a video or a still from a video of Tina Anderson, who's really a pioneer in this field in Norway, and she is titrating a cough assist device using laryngoscopy, so basically a flexible camera to look at how the upper airway is affected by the cough assist. What we have found is that many patients with significant bulbar disease, so involvement of the speech and swallowing muscles, can actually have a adverse reaction to the cough assist, and it can be very difficult to do this successfully in bulbar disease. It often requires a lot of working with the patient and the caregiver to get the settings, as optimized as possible, which can often be improved, but remains a challenge oftentimes in significant bulbar disease. Okay. What about feeding tubes? So from a respiratory standpoint, feeding tubes are also very important. We always discuss along with our neurology colleagues and our colleagues in nutrition um, and gastroenterology, timing of feeding tube and when to consider initiating it. Obviously, difficulty swallowing, significant weight loss, aspiration or choking events are signs that this is something we need to begin to consider. Um, Feeding tubes are normally placed endoscopically, so using a camera that is put down into the stomach, and then through the skin, a small tube is passed into the stomach, um, so that nutrition can be given directly, and you can bypass those swallowing muscles and reduce the risk of aspiration. We generally like to do these procedures on the earlier side, and that's for a number of reasons. One, the sedation associated with the procedure itself poses some risk to patients with respiratory muscle weakness, and there are increased risk of respiratory failure the longer you wait to do it. The other reason we like to do it early is because we know that respiratory muscle weakness, like all muscle weakness, is worse with malnutrition and significant weight loss. Um, and we also want to avoid unnecessary aspiration and risk for pneumonia in these patients. Now, if we think a patient is very high risk for a traditional endoscopic placement of a feeding tube, we can also ask our colleagues in interventional radiology to place a feeding tube without requiring any sedation. They can do it under just local anesthesia sometimes for us. So that's a multidisciplinary discussion that we often have with them. One thing to note that also comes up a lot for us that may have been discussed in some of the other sessions is that even after a feeding tube is placed, patients are still able to eat orally for pleasure. It just means that they're not required to meet all of their caloric needs via eating and swallowing by mouth. So their caloric needs can be met via the feeding tube, and then pleasure feeds can be given on a, as much as they would like and can tolerate. Okay. What about oral secretions? So this is a big issue for many of our patients, and again, increases the risk of aspiration. Um, Normal saliva production is about 1 to 2 liters per day in all people, and ALS does not affect that at all. But difficulty with swallowing can lead to pooling of those secretions. Um, Most patients who have excessive oral secretions and difficulty managing them can be managed with medications alone. There's a number of medications that you see listed here. Probably the most common ones we use are glycopyrrolate, which can be given orally or as a solution through a feeding tube, or atropine drops, which actually can be given sublingually, so beneath the tongue and not require any swallowing. And those can help to dry out the secretions. Amitriptyline and scopolamine are also other options as well. Um, We also will often prescribe portable suction machines, and you can see a device down here on the bottom right. And that's, again, a machine just like when you go to the dentist and they put the little plastic tube in your mouth and it kind of sucks out all those secretions. Many patients find that to be very helpful, including those who cough and are able to get some secretions up, but then have difficulty either swallowing those secretions or getting them out. There are additional options for more severe issues with secretions that the medications and portable suction can't manage. Botox therapy is an option, so we can refer patients to physicians who will inject the salivary glands directly. That often needs to be repeated on an about every 3-month basis in order to maintain its effect. There are additionally options for either radiation therapy or just removal of the salivary glands, but that's generally third line. One other option that we also, frequently offer patients is for patients who just have thick secretions. Things like pineapple juice or papaya enzyme extract can help just to thin out those secretions a little bit. Okay. As we get towards the end here, I just wanted to give a quick plug for the multidisciplinary care team in ALS care and in complex diseases in general. This has been studied in a number of different complicated disease states in cystic fibrosis, in children with serious illness, and in patients with ALS. And starting all the way back in the early 2000s in a study from Ireland, there's been data showing that survival of patients who go to a multidisciplinary ALS clinic is improved compared to those who do not. So it's something that we think is really important for our patients if they're able to get to a multidisciplinary clinic to do that. Now, what about the role of pulmonary medicine in this multidisciplinary clinic? So traditionally, pulmonary medicine was not considered a regular part of the ALS multidisciplinary care team. The orders and management of the respiratory devices was managed purely by the neurologists. The durable medical equipment companies would then sort of usually take on the respiratory care once those initial orders were written, and there was generally pretty limited follow-up for a lot of those respiratory needs. More recently, and at some very specialized centers, there is pulmonary medicine that has been integrated into this multidisciplinary care team, and we do think that's been an important advancement, where is that close relationship between the pulmonologist and the neurologist, but it still often involves pulmonary medicine sitting a little bit towards the outside of this circle. So what we've done here at NYU, under the leadership of Dr. Jinsey Andrews, our neurologist, and Dr. Philip Choi, my boss, who are co-directors of our multidisciplinary ALS clinic, is created a true kind of partnership model between neurology and pulmonary medicine in helping to manage this terrible disease. A quick plug now that we're at the very end, for a course, an education course that is for clinicians, but also has a lot of helpful information that can be used by patients and caregivers as well, is this course that was designed by Dr. Choi as well as Dr. Hansen-Fleschen at the University of Pennsylvania, called ALS Resp Care. It's free to sign up and watch the video lectures. So I think that is a nice additional resource if you want more extensive and focused information on respiratory disease in ALS. And that's everything I have. So thank you all so much for listening.
Well, thank you, Dr. Bain. That was such a great presentation. At this time, if anyone would like to utilize the Q&A box to ask Dr. Bain a question or make a comment, we would be happy to take those. If no one minds, I would like to ask a few questions to get us started.
Yeah.
Um, so one question I do have is, when do you begin the conversation with a patient and family about transitioning from a non-invasive ventilator to an invasive mechanical ventilation setup?
Yeah. So I think th those conversations ideally happen early. I would say the exact timing of it is somewhat variable, and again, often um, differs based on an individual patient's disease course. Really the reason to consider a tracheostomy is early on is usually in patients with more severe bulbar disease. And just as I mentioned during the presentation, the cough assist device can be more difficult to kind of tolerate. The non-invasive ventilators can trigger in patients with significant bulbar disease some laryngospasm and difficulty of basically getting the breaths delivered easily. So the bulbar disease patients can have somewhat of a more difficult course with the non-invasive ventilators, and I think at that point there's always important to discuss if if invasive mechanical ventilation and a tracheostomy um, would be appropriate and within a patient's goals of care, and something that they would be willing to consider. We'll say most of our patients do not have tracheostomies. That's not the most common route that patients go, but I think it's obviously always important to sort of have that conversation as early as it's starting to come up.
Thank you. Another question I have, you mentioned transcutaneous carbon dioxide monitoring as being as close to an arterial blood gas as you can get. Is it possible to have one of those in the home, and would it have value?
Um, It is unfortunately not really realistic to have one of those in the home. They are quite expensive, and would not be covered by anything. I mean, we're talking many thousands of dollars, and then the kind of disposable components for each time a measurement is taken are also pretty expensive. And to be honest, I'm not sure of what the value of having one actually would be. That is not to say that there is no value. It's actually an area of active investigation and study. Jason Acriveau at Penn is, involved in research looking at using transcutaneous CO2 in ALS patients at home. So that is, I think, somewhat of an open question from my standpoint, but it's not clear that what the value is, and certainly the cost would be prohibitive, and it's not something that can easily sort of be provided by a DME company. So right now, that is not really an option.
Okay. And then the last question I have is, how much does your team communicate with respiratory therapists in the field in terms of managing NIV settings in the home? Because I know you mentioned you can't really mention change settings remotely on NIV.
Yeah. So we're very fortunate to have a very close relationship with the DME company that we use, where we know those respiratory therapists quite well and have pretty open communication with them. I don't know if that's always the case, and I think in many places it's not as much the case as you would hope. So I think that can be a big challenge. Um, you know, these DME companies are kind of by law not formally affiliated with the physicians or with the hospital system in general. Like they have to be separate. So that separation does lead to sometimes poor communication and can be a challenge, but we do everything we can to keep that relationship as tight as possible. Because there are eyes and ears, kind of out in the world, and seeing the patients in between our visits when we can't. We will sometimes, in communication with the patient, know that there's an issue, at home, and we'll reach out directly to the DME company and the respiratory therapist. We can have a discussion with them about changing those settings. Um, Technically, in order to change those settings, you need a new prescription for the settings. Some respiratory therapists are a little bit more flexible with kind of, if they're there in the house and you're on the phone with them, making some adjustments and sort of seeing how the patient, responds. But that's kind of a case by case and relationship by relationship basis of if they're willing to do that. Um, while we can adjust the settings on the um, the BiPAP machines remotely, um, we don't always want to do that because it's oftentimes very helpful to get um, the immediate feedback from, we sit in clinic with the patient, they wear their device, we see how their breathing is on the machine, we can make small adjustments, they can tell us how it feels, we can really dial things in a way that if we're just, changing settings and waiting for them to sleep and give us feedback, then really, it's much harder. So oftentimes, I know for a lot of our patients, it's really hard to get into a visit. Bringing the device is certainly a pain, but in the long run, I think oftentimes that it leads to better long-term comfort and care with the non-invasive ventilators.
Great, thank you. And we do have one question in our Q&A. Um, are there some tips or tricks to help patients get comfortable using a BiPAP machine? Some patients have complained about keeping it on for 4 hours due to discomfort.
Yeah. So, it's certainly a challenge, and both in our ALS patients, which has some unique challenges due to the bulbar symptoms, but also, in patients in general, getting used to BiPAP is difficult, and many people find it uncomfortable at first. I'd say a couple of thoughts. One is that we try to start our patients on with ALS on BiPAP as soon as possible. So once we basically can get insurance approval for the devices, we generally recommend starting it and prescribing a device. Even if their symptoms are relatively minimal and their carbon dioxide looks good and everything. And there's a couple of reasons for that. One, we know that those patients, if they were to get a respiratory infection, their symptoms could get much worse much more quickly. So we want them to have a device at home where if they need extra support, it's already available to them. But two, we want to start them on really low settings before they really need it, and just give them some time to get used to, the sensation of it, the feeling of that pressure, and give us feedback before they really need it, to make adjustments, to get them comfortable with the length of the breath, the way the breath is delivered. Many, it depends on where you're practicing, but some places they may not have the expertise in setting up these devices. And I think one of the reasons we think the pulmonologist being really central to the multidisciplinary care team in ALS is because the respiratory devices are such an important part of this care, and it really does require some expertise and subspecialized training in how to manage these really well. And while some respiratory therapists are truly excellent and have a lot of expertise, I would say there's variability in that expertise and experience with dealing with patients with neuromuscular disease and being able to get those settings really dialed in. So I think, making sure you're seeing a pulmonologist who can help you adjust those settings, who has experience, because most pulmonologists, unfortunately, don't have any experience dealing with neuromuscular disease and titrating BiPAP or home ventilators for that patient population. So really seeing someone who has experience doing this can get you on the settings, can start you off slow and make sure it's working for you and it's tolerable. And then making adjustments, because at the end of the day, like sometimes we just need to sit there with the patient in clinic and get things sorted out. So it can be a little bit of a back and forth. I think a little bit of patience goes a long way because it's difficult, and sometimes hitting those 4 hours can feel very hard. I will say for the absolute kind of insurance requirement, a lot of times patients who maybe not be able to tolerate it initially just when they're sleeping, can tolerate it while they're awake during the daytime. So what we often tell patients is, hey, even if you can only do an hour at nighttime or can't yet wear it when you're sleeping, just to kind of get you used to it. You can just throw it on during the day. I know you don't need it right now, but we want you, one, to get used to it, and two, we want to make sure we're hitting this 4 hours. So if you're at 3 hours and 40 minutes and you had to rip it off in the middle of the night, no problem. Just make sure you go put it on for 30 minutes, after breakfast or something. So that's kind of how we counsel patients.
Well, thank you so much, Dr. Bain. This was such an informational um, session, and we're so grateful for the work you've chosen to do because it is such a big part of the ALS multidisciplinary care team. That concludes our session for now, and I would like to invite you to our next session starting at 1:30, and it is A Pal's Perspective, Finding the Upside in ALS. So thank you all for joining and have a great afternoon.
Bye.